I'm Maria Hall Brown, and this is LA Currents. Well, he has said you can absolutely hate the idea of homelessness, but the important thing is to love those that are unhoused. I'm delighted to be joined today by Brett Feldman. He's the director and co-founder of USC StreetMedicine. I am completely captivated by everything that you do and what you have been able to accomplish at this point. So my very first question is, what prompted your decision to take your medical expertise and take that to the streets, originally in Pennsylvania, but now in Los Angeles, to those that are unhoused?
Yeah, thank you for having me. And just like everything we do, we want the streets to build the program, and the streets really are the ones that brought me out from the hospital. At the time, this was 2007, I was working as a hospitalist, and we also ran a shelter-based clinic. And there was one patient, there's always that sentinel patient, who was very dear to us, and he had an intellectual disability. He was in his 40s, but intellectually was about 8 or 9. And he ended up getting asked to leave the shelter where we were staying, or where he was staying. And we were worried about him because it was January in Pennsylvania, that he wouldn't know how to survive, that he would freeze to death or starve to death. And so I went looking for him and found him under a bridge not far from where the shelter was. And I remember walking down this embankment, peeking under the bridge, and he's like, "Hey, Brett!" So excited to see me. I was so worried about him, but he was doing great. He was sitting by this fire with his new friends, well-fed, well-clothed. And so I kept visiting him and got to know his friends. But I didn't know this was called street medicine. My employer didn't know, my malpractice carrier didn't know. I eventually told them, and it turned out okay. But there was one, that's how it started, but what kept me out there was one of his friends ended up having severe abdominal pain, which turned out to need surgery that night. It was an acute abdomen. He walked 6 hours to the hospital to see me because he knew I worked there still.
Oh, wow.
And this was pre-Obamacare, and the practice I worked for didn't take insurance. And so he walked over there to see me, and I had to go and tell him that even though I would see him under the bridge and that he walked so far, I would not be the one to care for him. And I remember the look in his eyes of sadness and betrayal that was like, "You see me under the bridge, but here you don't know me." And I was so ashamed of myself and so ashamed of my profession. I just wanted to rip off my pressed white coat and never put it on again. And I think in a lot of ways I did that day, and just wanted to be out there with them under the bridge. I went back and asked for forgiveness, and by their grace they gave it to me. And so then I just wanted to stay outside.
So how did you create the street medicine program in Pennsylvania? How did you get the powers that be to sanction it so that you could actually help these people that you have gotten to know and even more since?
Yeah, they believed in the mission because they believed, to begin with, that the charge of the hospital that I worked for was to care for the community, not just the people within their walls. And so once we kind of let them know there were a lot of people outside of their walls, the next logical step was that responsibility to create something for them. So I was able to get a grant which bought a day a week of my time. And with that day started street medicine, consult service in the hospital, and another shelter-based clinic. And then that allowed me to get another grant to buy all of my time from the hospital.
All right, so rural Pennsylvania, and by the way, there's a great film if people are interested to see what you did in rural Pennsylvania. Allentown, Pennsylvania, and the rural areas and those that are actually unhoused in that area could not be more diametrically different than Los Angeles. How did the opportunity to come to Los Angeles present itself to you, and how did you make that decision? Because this is such a huge problem, if not the most prominent problem in this area. How did you say, okay, I can do this?
Well, I still don't know if I can do it.
Okay.
So I do this work with my wife, Corinne. and also work for the International Street Medicine Institute, which is the international street medicine body. And so I came here, I think in 2016, as a consultant from the Institute. Because at the time in LA, there was only one other street medicine program. It wasn't something that was done in a city like this ever before. But through the Institute, I had also traveled around the world and seen street medicine and homelessness in many different cities and many different countries. And when I got here, I was just blown away by the magnitude of the crisis at that time, and the numbers are even higher now. I was also blown away by the desire of everybody to want to solve it, and that even though to me at the time it seemed like it was so insurmountable, nobody I met felt that way. Every day they wanted to go out again and do something different and something new. And I met folks on the street, and they inspired me. So between them and the people that I met in LA, then we decided to give it a chance.
Okay, so let's clarify exactly what this Los Angeles version of street medicine is. I mean, I think a lot of us are aware of, mobile clinics, or, even all those Winnebagos that would go around and do, dental exams for underserved communities. This is not that. This is something different. This is something more personal.
Yes, that's right. So street medicine is distinctly different from mobile medicine. Both are very much needed, but the difference, there's a philosophical difference and a practical difference. So philosophically, we want to be able to suspend our reality and meet the people in their reality where they feel most comfortable. Even if we drive in proximity to them, we take them out of their environment into our environment that we've probably even licensed. We've flipped that power dynamic back in our favor where we don't want it. We want them to have the advantage in the power dynamic. Practically speaking, that even if a mobile unit is mobile, when it parks, it becomes a fixed site. And so if somebody can't leave their encampment because everything they own will be stolen to go to a brick and mortar clinic, they also can't leave to go to the parked mobile van. And so rather than relying on people to leave and go to the van, we go to the people. With pickup trucks and backpacks, we proceed on foot. And know that healthcare is more than an office visit, even if that office is under the bridge. So we dispense medications, draw labs, do ultrasound, EKGs, everything in the patient's environment where they feel most comfortable.
That whole power dynamic is fascinating to me, because you talk about you go to where they are, but you also go to where they are in with a different approach and a different attitude. I mean, even how you posture yourself when you speak to people, when you're getting to know them, is an important part of your philosophy of how this works. How did that come into play, and how did you understand that that was important when you're dealing with people who are already in horrible crisis?
Yeah. The values and philosophy of street medicine are, being able to share in some of their suffering with them, be in solidarity with them, being willing to not just give out of what's extra, out of an excess, but give a little bit until it makes you uncomfortable, because that's the equitable thing to do in their state. And I learned that because I've seen so many programs that try to address one of the different types of poverty that they suffer from without addressing all three. And so there's the material poverty for want of a home or want of food. And we ask our folks a lot of things. Outside of Skid Row in LA, many people are only getting 2 to 3 meals a week. And so how do you begin to think about things like your health care or getting a job or doing anything if you're starving? There's the poverty of health. Over 80% have a physical comorbidity disorder, about 60 to 70% with a mental illness, and about 60% suffer from a substance use disorder. And if we don't treat that now while they're on the street, they're not going to, one, live long enough to get into housing. And if they do get housing, they're not going to be able to walk over that threshold into housing or keep that housing if they're sick. So there's the physical poverty too. But it's the spiritual poverty of feeling unwanted or unloved by anybody. A poverty only deepened every time, for example, a neighbor locks a public restroom on another neighbor, forcing them into the dehumanizing act of open defecation. And we know this is about 85% of the people in LA. And it's not because they want to, it's because there's no bathroom open to them. Or anytime a neighbor calls to have another neighbor's place moved, pushing them around the city that they feel is their home, but there's no place to put their physical body. So it's that, being seen and treated like a contagion, or like the trash that they're thrown out with, that needs to be addressed before they can ever be spiritually housed.
So how do you make these relationships, and how many relationships can you physically make and assist? Because this seems, how many unhoused do we have in this city at this point? What was the last count?
Yeah, for the unsheltered, because that's who we serve, it's about 50,000.
Okay, you cannot possibly make a relationship with 50,000 people as long as you live. So
yeah.
What are you able to do, and how are you able to do it? Because even the points that you just made about, the trial and tribulations that they're facing on a daily basis, how can they be moved into a different scenario in which that suffering is somehow abated? How do you manage this?
Yeah. So a number of things. One is it can't just be me.
Right.
And so we have a team. Right now, USC Street Medicine, we have, I guess, about 50 employees. We have 5 full-time teams that cover the city. There's also other street medicine programs in the city, and it's growing. And we have our partners to share the work with. That said, we're still only meeting a small percentage of the people. So I don't go out every day thinking, how do I care for 50,000? I go out thinking, how do I care for one? And then the next one, and then the next one. That's the attitude that we go with.
And you've had success. You've had success with, there are a number of hurdles, obviously, but you've had success with the one-at-a-time approach. What are some of the things that you are grateful that have happened based on the efforts of those that you work with and those that you work for?
Yeah, so there's the measures of success that people like to hear, the metrics.
Sure.
And so as far as that goes, for example, we've been able to decrease hospitalizations by about 70%. Since 2018, we've been able to house between 30 and 40% of everybody we see, and there's a number of reasons why those numbers are so high. We can talk about if you'd like.
Yeah, I'd like to.
So the reason why I think they're high is because medicine is seen as an instrument of peace, where you can go to war-torn areas throughout the world, the Red Cross, Doctors Without Borders, and be seen as a neutral party there to help. And so we go to areas that look very similarly. And I go with my stethoscope on, it says Street Medicine on my shirt, and so they know right away why I'm there. So then we can form relationships very quickly through that. We begin treatment immediately once they agree to it, and most agree to it very quickly. Then we refer into housing. And while they're waiting 5 months, 6 months, a year for housing, we keep them engaged. So when housing does come through, we know where they are, we haven't lost them. We meet people all the time who have a housing voucher they don't even know, or had a housing voucher that's now expired because they were lost. So we know where they are, and their physical health's better, mental health's better, they're using less drugs, so housing is more likely to be successful.
How are you keeping track of them? Because I've heard you say people move 4 to 5 times a month. So how are you keeping track of them?
Yeah, we have community health workers, and these are people with lived expertise in homelessness. They know the streets better than anybody. And so their main job is to follow people so they don't get lost. And there's a number of tricks of the trade that we use. They're the main reason. But also we'll ask them things like, we call it a homeless advance directive. If you are moved, where are the next 2 or 3 places that you'd go? Or we learn their daily routine, just like you and I have a daily routine. So if I know that Joe's gonna panhandle at this corner around 11 and his encampment was moved, I'll meet him there at 11. And it's not foolproof. We still can't find people sometimes, but it does help.
Along the lines of You know, I've also heard you talk about the whole idea behind, you know, just medicine at large is to kind of keep that distance from the patient. Obviously, bedside manner is important, but bedside intimacy, well, in a non-weird way, is not necessarily, you know, encouraged, because a relationship, you know, creates a lot of emotion, and a relationship creates a lot of responsibility. How are you able to cross that bridge while still protecting yourself, while still doing what you want to be doing in order to help these people?
Yeah, so I don't think this is unique. This phenomena you're talking about is not unique to medicine.
Okay.
Although I think it is most evident in medicine because we care for people who are suffering. And so anytime you deal with somebody who's suffering, and in every, this is not just on the street, but every hospital and every ward, there's somebody that's scared and suffering. Mm-hmm. And so we're trained, you know, don't get too close, and it's not just medicine. Don't get too close, no hugging your patients, no crying with your patients. You're gonna, you know, it's gonna cloud your clinical judgment and you'll make a wrong decision. So then we go out into the world and we meet people scared or suffering, and we have a choice. Do we engage them in that suffering and therefore maybe expose ourselves to a little bit of it? Or do we retreat and protect ourselves? If we've been trained that the professional thing to do is retreat, we'll choose that every time. But in doing that, we've left them isolated. We've also isolated ourselves with the knowledge that we've abandoned the people that we've dedicated our lives to serving. And so that's why in medicine you hear so much about burnout. It's not burnout, it's actually moral injury from doing that over and over again, 15, 20 times a day, leaving somebody that you've dedicated your life to serving abandoned. And it's like that in many professions. And so I actually think the way to protect yourself is to engage, is to share in the suffering, relieve some of that, because it gives you a healthy way to exercise what you're seeing, rather than just trying to smush it down and pretend you didn't see it.
But sometimes you can't fix it. So how are you? I mean, because this is a profoundly different approach for a number of reasons. Not to say, as you said, you've met a million people out there that care and want to help, but this is a profoundly different approach. How are you maintaining your internal stalwart ability to continue, because you can't always help?
Yeah, that's a great question. I think we can always help. It depends on what the goal is. And so we have to remember, we didn't cause this situation. Like, I personally did not cause them to be homeless, or I didn't cause them to be starving, or I didn't cause that cancer. And so if the only way that you consider that a success is if they're housed and have a job, then you'll feel like you've been a failure. But there are sometimes that people die on the street, and we know that, you know, they died knowing that somebody cared for them. Like, I'll give you an example. I was doing some, I was visiting one of the other street medicine programs in LA, and the team was just so distraught because one of their patients had essentially drank himself to death in his tent. And they felt like they were such a failure. And if you look at it from a purely medical standpoint, it seems like a failure. They were supposed to care for his substance use, and that's what he died from. If you look at it from a social service standpoint, it seems like a failure. He was a veteran and actually had qualified for housing, had a housing voucher, but they hadn't placed him yet. And they listened to messages on their phone, "Where's my housing? You promised me housing." But then before he hung up, he would say, "All right, I love you, bye." And when he passed away, the occupational therapist was listed as his next of kin. And so what a beautiful gift they gave to him, to die knowing that somebody cared about him. He had a name to write down. And how horrible it would be to have nobody that you can write down to say would care about you if you died. And so from the standpoint of love, it was a complete success because they shared that gift together.
I knew you were going to make me cry. I mean, of all my prep and all the things I've learned about you, you know, I was going to be very stalwart, and I knew, but You got me. And I guess that's maybe something that needs to be addressed, is because, as you mentioned, everyone is looking for, the success. Everybody's looking for the problem being solved. Everybody's looking for the money to no longer need to be spent. All those things that are important, because there's been an enormous amount of energy, effort, money. But what do you want people to understand in regards to not the problem, but the people? Because you've gotten to know the people, and I think that the stats may not reflect who it is that we're referencing. Everyone has this feeling now that it's a bunch of people with mental illness and drug problems and substance abuse issues and or choice, all those things. What are we missing? What do we really not know that we need to be so much more sensitive to? And who are we talking about?
Yeah. So I don't know everyone individually, but I've been doing this since 2007. I've met a lot of people, and they're beautiful people. And I want people to get to know some of them, not as a statistic, but actually as a person. And when you get to know them, then you change some of the some of the things that you would do to solve this crisis. And so in general, we need all these programs. We need housing, we need outreach, we need all those things. But homelessness will never be solved by that alone. And so it's a decision that we as a city, we as a society need to make. It's what you mentioned in your opening. We have to be able to separate the person from their housing status, to hate homelessness with everything that we have, but to love the person even more than we hate homelessness, and see how the policies would change if we treated it that way.
Okay, so here I am. What can I do? I mean, I don't have any control. I don't have it, but you also feel that it's imperative that everybody participate beyond those that are actually charged with or hired to.
Yes. So what everybody can do, because it's LA, we see people experiencing homelessness every single day. There's probably somebody that you see coming off of the freeway every day, holding their sign, asking for food. There's probably somebody outside the studio that you see pretty regularly. And as many people as are experiencing homelessness, there's more people who are not homeless. And so if each of us found one of those people that we see every day, and we got to know them, what their name is, what their hopes are, maybe we bring them food, we take care of that one person, then we would solve the crisis.
Well, we've all been told not to give money to panhandlers, that they're just going to go and end up, buying fentanyl or something awful. And then I'm a woman, how do I know the behavior of who is in front of me? I mean, what are the realistic fears and what are the false fears of interacting with someone as you suggest?
Yeah, there's a lot of biases that people take on once their housing status changes. And, the way I hear it is like, people experiencing homelessness are just mentally ill on drugs waiting to jump out the bushes and get you. Mm-hmm. And that's just not the case. And what we're saying to do is very low risk. Walking by somebody or walking by them anyway, you can certainly give them something as you walk by. In terms of if you're going to give money, if you're going to give food or socks or whatever, if you're worried about that, you can't go wrong with giving socks and water. Because everybody needs water, and they probably are hungry also. So if you want to carry some flip-top cans of, some sort of hearty soup, because they don't all have can openers, that's also a great thing to give if you don't want to give money. Some people are fine with giving money. That's a personal choice. I feel like whatever money I have, my employer doesn't tell me how to spend my money. That's up to me. And so if I choose to give money, however they spend their money, that's up to them. Mm-hmm. That's my personal feeling. But if you don't feel comfortable doing that, or not you, but people watching, mm-hmm. then those three things you can't go wrong. Flip-top cans of soup, socks, water.
You've been in Los Angeles now with this street medicine program for
6 years.
6 years. How are we doing? Are we getting better, or are we getting worse?
I actually think we're doing better.
Really?
I don't think we're, if you look outside, it's not almost solved or anything like that. But the reason why I say that I think we're doing better, and this is not necessarily a reflection of the numbers, I think that's a different discussion, is that in terms of street medicine, we were the second street medicine program in LA. There's 14 now. We're still only seeing a small fraction of who needs to be seen. But at any place you go in the city, there's somebody you can call. They might not have the capacity to see everybody, but somebody is covering that part of the city, and that wasn't the case before. I've also actually really enjoyed working with Inside Safe. And they need more beds. I mean, everybody needs more beds. But the thing I like about the Inside Safe operations, and I've been a part of these operations, is it's a choice for the people. So you go to it's not a sweep. It's not pushing them around the city. So they choose a encampment or an area of the city, and they say, everybody here, if you would like to go inside, this is the location where you can go. If you choose not to go inside, we leave you and all your stuff there undisturbed. And by and large, almost everybody chooses to go inside. If there's an area of 30 people, maybe you'll get one or two that doesn't go. But it's really destroyed the belief that people don't want housing. They do want housing.
We've spoken a lot about the relationship and the emotion, but we should also very practically talk about the medicine in the amount of time we have.
Sure.
Things that you were able to do, obviously, help the issue of them needing to get to an emergency room, because usually that's the only choice. But what can you practically do in the field that will really legitimately help the health of an unhoused individual?
Yeah, we can do pretty much everything in the field that you can do in a brick and mortar clinic. The only thing we have trouble doing are pelvic exams. Everything else we can do. And so in that, we can access the patients because most of them cannot get to a brick and mortar clinic. For example, and this is an issue that does need to be addressed, between 60 and 80% of the people we see are insured. Only 7% have seen their primary care doctor in the past year, because most of them are brick and mortar, and only 3% are actually getting behavioral health care. And so we have to take it to them. That's the solution. And so we do a lot of wound care, but we also treat chronic disease, diabetes, hypertension. We can treat people with mental illness. So we prefer, for example, to use long-acting injectable antipsychotics. I give one injection. It lasts a month or more. It's never lost or stolen or traded or degraded by the elements. It's in there. And we've seen tremendous results like that. The other thing we can do is we can actually treat substance use disorder. So, there's a lot of talk about harm reduction, handing out clean needles and things like that. And that's important, but it's also important, if not more important, to be able to treat it. And so we can treat that with medication-assisted therapy is how we help them stop using opioids. So all this we can do on the street.
I could talk to you until tomorrow, but unfortunately, we do have to wrap it up. But, if people want to learn about what you're doing and about what they can do and about how, this process is working and about how everything is, how they maybe can help you, if not, what's the best way for them to get in touch with you?
Yes, if they want to get more information, they can visit our website for USC Street Medicine.
All right. Thank you, Brett. Thank you for everything you do, and thank you for being such a compassionate person.
Thank you.
And that's a wrap on this LA Currents.